Technical procedure of the first metatarsal phalangeal joint arthrodesis. And the first thing we're going to do is bring the patient into the operating room on a supine position and give them anesthesia. That will entail a MAC and a local anesthesia. MAC is most likely going to be propofol IV, and the local will be a lidocaine injection around the surgical site. And when that happens, we're going to call a timeout, and which entails 7 steps. Correct patient, so patient ID, correct limb, correct surgical site, any known allergies. The anesthesiologist will announce any drugs that have been previously given, fire safety level, and then everyone else is going to go around the room, announce their role and their name, and then we can time in. That's when we're going to approach the patient here, prep and drape them. So once we've done all of that, prepped, draped, exsanguinate, apply the tourniquet, we can map out our incision, and then we can make our incision with a size 10 scalpel. And once you make your skin incision dorsally, you're going to want to retract and dissect a little deeper into and pull nicely these neurovascular structures that are there. Then we can dissect a little deeper into the joint capsule called the capsulotomy. And at that point, we are going to also release the collateral ligaments and free up this joint as much as we can. And when we do that as well, we're going to need to release the joint a little bit further using a Glamory elevator. This is going to go plantarly under the first metatarsal to free up the sesamoids that are here, that are still adhesion there. So this is completely free now. Obviously this plate wouldn't be on yet. So this whole joint is free, you're able to move it around. Then we're going to cup and comb ream. So the cup is going to go on the first metatarsal head, and the cone is going to go on the proximal phalanx here. And then once you've reamed, you can also, if the surgeon has a preference, to use mechanical hand tools using an osteotome and a mallet. If they don't want to use those, they can use these if they're old school like that. And then after you've done that, you are going to want to do a saline wash because you've made sort of a mess with all this bone dust. Wash that out so it's nice and clean. And take a 2.0 drill bit. You're going to fenestrate both sides of the joint space here. So distally and proximally on the phalanx and also on the first met. You're going to fenestrate here, and that sort of prevents, or promotes, I should say, bleeding, and it also is going to make a better timely fusion of the joint when we put that together. So that's sort of the idea there. And while this joint is completely fenestrated, washed out, and free, this is where we can make our alignment, which is ideally going to be 10 degrees dorsiflexion and about 10 degrees of abduction. So we're going to correct the deformity here at this point in the procedure. And to do that, we're going to put the joint in the alignment that we like, and once we're happy there, put a temporary K-wire across the joint space so that fusion can happen nicely here. Or you can use multiple, go this way, this way. Ideally, it's just going to be across the joint space so you can at least make this fusion happen, and it's also timely because we just fenestrated, right? So we want to do some sort of internal fixation temporarily to get that to happen. And so once that's in there, you can do a fluoroscopy image to make sure that the alignment's happy, the K-wire is in a good position, and now you can get ready for our interflag screw. And to do that, so this will be in here, we're going to use a Lagby technique, which is an over drill. It's going to be only on the near cortex here, and then you're going to under drill. This is going to be a 3.5 size drill bit, near cortex, and then under drill bicortically through the far cortex. And once you've done that, you're also going to need a countersink. And this is what this is going to be for. And this countersink is going to give the screw a sort of a bed so the head won't protrude outside the bone. It'll sit nice and flush against the bone. And that's the only time you're going to need a countersink. So once you've done that, you really won't need to use this again. So we can put that to the side. And so once you have made your drilling and your countersink, you're going to measure. Take your depth gauge here, go all the way through the bone, hook the other side, get a measurement. Scrub tech is going to know what size we're going to use. Once we get our screw, you can then put it in across the joint. This needs to be across the joint, so obviously when you've made those holes, you'll see bicortically across the near and far cortex. That screw is going to go across the joint, and now you can finally take your temporary, it's going to be non-locking screw as well, correct? Or inner frag screw is what you can say. And once that screws in, you can pull the K-wire out. And once you pull that K-wire out, you do need to make sure that that screw didn't loosen, so you can just double check for tightness on that. And once you've put the inner frag screw in and everything looks nice, take a picture, obviously, because we just put a screw in, so you want to make sure that that's all nice. And once you've done that, we can select our plate. So I guess we can come over to here now. We have our frag screw in, and we're going to select a plate. Scrub tech knows the size. That's good. Oh, also I forgot to mention, every time you use a drill bit, if you're drilling, a good idea is to use the soft tissue protector. It also makes sure that your drill bit is straight, and so you're not doing any of this. So you can kind of go straight in anytime you drill. That would be done previously as well. But for this procedure, it's just not using it. But obviously every time you do drill, use the soft tissue protector. And so now we're on a step where we select our plate. Once you have your plate selected and you're happy with coverage here, you're going to want to temporarily fixate this. And to do that, you'll use BB tacks. But before this plate is, when this plate is given to you, it'll come preloaded with these fast guys or drill towers. So you'll know which holes are sort of available for you to use. Just a rule of thumb, it's going to be proximally and distally across the joint space. I can put this last one in, but I'll just go here. One BB tack proximally and one BB tack distally across the joint space. And once you have that temporary fixated, you can then go for, look to your non-locking screws, which is what you're going to use first. And to do that, similar to before, you're going to over drill and under drill with the 2.5 and 3.5 millimeter drill bits. You don't need a countersink because there is this plate here. The head's just going to sit in there. The idea behind the non-locking screws is that it's going to compress and suck this plate to the bone. That's why you put these first, and that's why they need to go proximally and distally across the joint space, or I should say, not across, but one on the proximal side, one on the distal side, so the plate sucks to the joint space. And now you can look to do your, obviously before you place those, you have to take off the drill guide so you can put those screws in. So it'll be something like that with non-locking screws in proximally and distally. Now you can look to place your locking screws, and to do that, you're going to only have to under drill all the way through bicortically through the fast guides. So these need to be on. And obviously this drill bit was able to go through, so you know that's the right one. You won't even be able to stick this one in because it's too big, so you have to only under drill. And obviously no countersinking happening. And once you've made those holes, you can take your fast guides out. And then you'll measure and place your screws. That's going to be using this ratcheting screwdriver. So we'll measure, get our screw length, place our locking screws so that the head will actually engage with the plate and sit flush against the plate in recess. So there's no countersinking, like I mentioned earlier, needed. And then once that's completely done, we will do some more fluoroscopy, and at the same time do another saline wash after we've made some more bone dust. And now we're getting ready to close. So what we'll do first is the joint capsule closure, layered closure, then the skin, and then once that's done, we will bandage up the patient and release the tourniquet, and we're done. That's it.